Okay, we're going to wrap up Module 7 by discussing some of the common approaches that are used for people going through drug and alcohol treatment. It's not important that you develop a proficient knowledge of these approaches. That would simply be unrealistic given the constraints of this course. We just want you to be conversant in some of the approaches that are taken so that if you're dealing with people who are in the pre-contemplative or contemplative stages and they have questions about what might happen in treatment, you'll be a little bit better versed in answering those questions, thus demystifying it and reducing fear and anxiety so that people feel it's more accessible and realistic to get help. And we also want you to be a more discriminating consumer out there. So not every approach we're about to describe is equally valid from a social perspective or equally effective from an evidence perspective. So we'll give you a little bit of that information, and hopefully my personal biases won't come through too badly. So the very first one we want to talk about, and by the way, I haven't put these in any particular order. The very first one we talk about is cognitive behavioral therapy, and sometimes the particular variation of this is called reality therapy, which is based on studies by William Glasser. Now, cognitive behavioral therapy simply means we want people to be aware, that's the cognitive portion of this, thinking about what it is that's effective for them, what works for them, what's reinforcing and what's aversive or punishing in their life. And so we have people start to think about choices that they're making from a perspective of what rewards will they get for making good choices and making and using behaviors that are effective, and what consequences will they experience as a result of not doing that. So this is essentially an approach that combines some counseling but also a variety of different sort of program approaches. For example, they may ask an individual to make a behavioral contract where they agree to behave in a particular way, and mostly they're making that contract with themselves and with their families. And we may also look at having people structure rewards and consequences around this sort of thing. Now, aversive therapy is down below cognitive behavioral therapy as a smaller bullet point because aversive therapy technically is a behavioral therapy, and it is still used. For example, you'll hear about people who are using a drug called antabuse. Now, antabuse is not a psychoactive drug. It doesn't actually affect the person's mind per se. What it does is it has a physiological response when a person consumes a drug. It makes them very sick if they use the alcohol, if they use alcohol. And so the idea is that the person becomes averse to using alcohol, that they don't get high from using it or get a therapeutic effect. They get simply a negative effect. And this is actually combined with other forms of aversion, such as people being flooded or turned off of alcohol through imagery, or even things like shock therapy. And not electroconvulsive therapy. We're talking about shock therapy, where people try alcohol and they get shocked as a result of doing it. So these therapies are still out there. There are some people who swear by them, but most of the therapies that are used today are addressing the underlying psychosocial needs of the addict. And the thing about aversive therapy is it doesn't really do that. And so the evidence tends to point to the idea that while this therapy has some very amazing numbers in the short term, it doesn't always have a lasting effect in the long term because we tend to have a poor memory of pain. We tend not to remember exactly how badly something felt. And these therapies tend not to work very well if people don't actually continue them. And that's the other thing we have to remember, is that a person may be turned off of alcohol or drugs, but 6 months or a year later, if they consume that same substance and don't get the same physiological response, then it won't be very long before the body unlearns what it had previously learned. In many cases, we combine medical and medication approaches now with the psychosocial approaches that we've used earlier. And as I said, this is done to address concurrency. More and more, we're starting to realize that people are utilizing street-based drugs, street substances, and prescription drugs that were not prescribed for them to address underlying psychiatric needs. And so it can be very, very valuable for us to have a person get proper medication and have other medical approaches as necessary. For example, a person might have diabetes or hypoglycemia, and that can be affecting their moods. They might have kidney disease, and that can be affecting their moods because they may not be purifying their blood the way that they should be, and that can cause people to be irritable. They may have a thyroidal issue. And so getting medical help is very, very important for these people. But it's important that we not only get medical help, we must combine with a psychosocial approach. Family therapies are quite common, and I think sometimes the public perceives them as being more common than they actually are. I think it's commonly believed that if a person has an alcohol or drug issue, it stems always from some kind of conflict with their parents or their siblings. And while there are examples of circumstances where that is true or where that is a factor, it isn't always true, and it isn't always the single most common factor. So having people receive family therapy is a valuable thing, and it's particularly a valuable thing where the family members have enabled the drug or alcohol use, or where there's been some sort of trauma in the past. But again, it's a part of the larger puzzle. Asset building is a growing an approach that is growing in popularity, and assets are simply attributes in a person's life that help them to be better prepared to cope and help them to socialize and manage effectively. These assets come in the form of external resources such as housing, money, pro-social family relationships and relationships with friends that are healthy, as well as the person's own physical health, as well as internal assets. And these are, for example, personal qualities and skills such as communication skills or coping abilities. And so oftentimes what's basically done is a person is assessed against a list of assets, a list of ingredients that people need in order to be effective in life. And their therapies address each of these, both in terms of, as I said, building the external resources, for example, reconnecting with family or getting somebody a job, and internal asset building, such as improving self-esteem and mindfulness or coping skills, or helping people to learn to socially navigate where they have conflicts presently. Narrative therapies have become very, very popular, and what happens in a narrative therapy is a person shares their internal narrative, the story that's going through their head about how their life is going and what will happen in their lives. It essentially deals with the idea that many of us live our lives based on predetermined self-fulfilling prophecies. We believe something will happen, and therefore it does happen. And often we have written stories in our past that don't actually reflect the past, or don't reflect the past in terms of the only possible interpretation, and we have used that as a way of seeing things very negatively. So for example, I had a conversation the other day with somebody who related that a parent had stolen money from them when they were a child. As we looked at that situation in a little bit more detail, what the person was able to realize was that the money that the parent had taken back was A, the money that the parent had given to them in the first place, and B, that the parent probably did that because if they hadn't done that, the family might not have been able to pay for groceries and rent, and they were doing this to actually support the family in the short term. So while that wasn't a pleasant memory and it wasn't an easy thing to accept even with the new narrative, the individual, through seeing a new perspective, could cope with it differently. And sometimes narrative therapy looks as simple as having a person describe how something is going to happen in their lives and looking at possibly different endings, where the therapist works with that individual to literally draw out or write out different possible ends to that story, and the person pictures themselves taking different approaches and later comes back to talk to the therapist about which approaches worked best and starts to kind of build up a new script internally, a new way of looking at things, a new way of interacting with people, and it's a way of gradually reorienting a person to some perhaps skewed and dysfunctional thinking. And this has proven to be one of the effective approaches for people who have personality disorders and or substance use disorders. And the next one is called dialectic therapies, and dialectic therapy is also an example of something that's been used effectively for people with borderline personality disorder and other similar issues. And dialectic simply means, in the simplest of terms, it means logic, but in this particular case, it really means having people make choices or see all of their behaviors as choices. And what the what the therapist does is help the person to analyze their decisions and to slow down and see how their behavior is not something that needs to always be done from a reactive standpoint, but how they can be mindful and thoughtful and analytical about the decisions they're making. And this is an ongoing and lengthy process because it needs to often address the fact that there are long-standing embedded social patterns for a person that need to be kind of unlearned, and that can be very, very difficult for most folks. But when we're doing that dialectic approach, we're getting people to do something similar to what they're doing in narrative in terms of telling you what their thinking is, as opposed to simply telling you their story, and starting to look at the choices that they can make instead of always sort of lumping in or making an assumption and jumping in and doing the same thing over and over again. Most of us are familiar with programs like Alcoholics Anonymous or Narcotics Anonymous. These are 12-step programs, and they're based on the Big Book. And the Big Book basically asks people to go through a progressive set of 12 steps, and those 12 steps for non-addicts can be kind of boiled down into fairly simple steps. One of them is that the person begins by accepting that they have a problem and that they need help. Other steps address a spiritual side of things, and this can be a struggle for some people because not everybody has a particular metaphysical bent and sees or believes in any kind of spiritual entity. But it's important that people realize that the 12-step program does not expect an individual to adhere to any particular religious idiom. It's not Christian, it's not a part of any organized religion, and what it's asking people to do is to sort of understand that there may be a higher power or a spiritual side of things. And this idea of helping people to realize that they don't have to master every aspect of their lives on their own, that they're not alone in the world, and that they can't control everything that happens in life is a very important thing, even for a person who at the end of it still doesn't believe in any sort of higher power. So that's one of the things that's in the 12-step program. It also asks people to take an inventory of themselves, see where they have assets, see where they have deficits, be honest with themselves, and go out and make amends with other people and make a commitment to improve. And as we get to the end of the steps are asking people to actually reach out and help others who've gone through the same sorts of problems, I should say, as the addict. Now, for some people, 12-step programs work magically and don't need to be really augmented tremendously through other supports. Whereas for other people, 12-step programs don't seem to work at all. It really is about a personal choice. And I've worked with a number of people over the years who have what we called worked the program, meaning that they have gone out and sort of religiously adhered to their 12 steps, but because they haven't really internalized the meaning of each of those steps, the person has not necessarily benefited in the long term. And as soon as they sort of waned in their application of the actual steps or processes, the person found themselves vulnerable to substance use again. On the other hand, I've worked with some people who seem to go through some of these processes before the book even told them to do so, before their sponsors even told them to do so. And they seem to really kind of register the differences. And even though traditionally 12-step programs suggest to people that they're going to need to be in recovery in perpetuity, some folks seem to have learned the lessons early on and not needed to return to the 12-step program. So each person is an individual, and I am not against 12-step programs at all. I think they can be an extremely important part of recovery for many, many people. One of the things we need to know about 12-step programs is that they are not run by professionals. They are run by lay people. In other words, it's done by alcoholics for alcoholics or addicts for addicts. And there are also 12-step programs out there for the families and the children of people going through families that are affected by addiction or alcoholism. For example, Alateen, as the name suggests, is a program for teenagers, not the addicted teenager per se, but the child of an addicted parent. And there's Al-Anon, which is for everybody in the family who is having to deal with that addict. And in some cases, people are actually sort of addicted to their addict, and this can be a very valuable resource as well. Now, many people will seek residential treatment while others will pursue outpatient treatment, and there's a significant cohort of people who will do both. So they'll be at a residential treatment facility for anywhere from 28 days to 2 months or even longer. In the case of, for example, Lydia House or others of our local programs, they often give people the opportunity to stay for an additional period of time if they feel that they need that. So residential treatment, as the name suggests, means that the individual goes and lives in the facility for that period of time. and a comprehensive array of services are provided within that facility. So there's going to be counseling, there's going to be education and group work, there's going to be opportunities for healthy recreation and outings, there's going to be life skills teaching, there's going to perhaps be 12-step meetings held in that facility, there may be worship activity, and there may even be access to a clinician, a psychiatrist or doctor through that facility. So people are often getting a number of things under one roof, so to speak. But it can be difficult for some folks to transition out of a residential system back into the community, especially if they're returning to the community where drug use was an issue for them. And so in many cases, people like to go into an outpatient facility where they literally are coming in and seeing a counselor 1 or 2 times a week, perhaps more intensely on a situational basis. They may again participate in meetings or group therapies, and this counselor may form sort of a core individual in their overall care. Some people only use outpatient treatment and access informal resources in the community such as 12-step programs, and some people, as we said, will leave residential treatment and transition into outpatient. Many people who are in outpatient care live in recovery homes, and recovery homes are not necessarily the same as a residential treatment facility, even though the name sounds as though that's what it's saying. These are often homes that provide sort of a soft place to land for an individual who's been through an organized, structured residential treatment facility, normally a place that's funded through Fraser Health in this catchment. And so these may be homes that are nothing more than a home that has 3 or 4 other people who have also come out of recovery. In some cases, there are local benefactors, people who are, for example, people who've gone through a recovery for a long period of time, who have provided a home at low rent to other individuals, so that they have a system of informal supports. And in some cases, these are actually staffed homes. There is, in some cases, a concern around the caliber of these homes, and we need to make sure that we do our due diligence in terms of making sure that the person is going to get actually supported. In Mission, I can tell you that when I was on council, we had to tighten up on the rules here, and the legitimate homes were very happy to have the regulation of the ones that weren't legitimate, because they were essentially taking money from recovering addicts and alcoholics, and as a result, those people were not only not getting better, but they were actually in many cases being treated so poorly, often crammed into a facility, that they were actually not improving, they were actually in some cases getting worse. Now you can see the bullet point I have below here, and it talks about detox versus treatment. A lot of lay people think that detox is the same as treatment. Detox simply refers to the medical process during which a person literally gets past the physical withdrawal symptoms of getting off of a drug. And this is particularly important in the case of heroin and alcohol. And in that circumstance, we would normally have the individual be supported by a medically supervised team. And this can now be done not only in a hospital-based setting, but there is home-based detox in the Fraser Valley. And so speaking to a general practitioner can help to create this referral where nurses will actually come into the home and be prepared to work with that individual over a 2 or 3 day period to help them get through these symptoms. But detox on its own is not treatment, and so the idea is that the individual needs to be able to move into treatment after they have done their detox. And that means that some collaboration or some relationship needs to be built between whomever is going to supervise the detox and whomever is going to help with the downstream treatment. And we also need to remember that not all drugs require much detoxification. For example, as much as crystal meth is a very intensive drug, from a detox perspective, it is a simpler drug to deal with than, say, heroin once again, or even alcohol. And so in some facilities, you'll hear them say, we don't take an individual until they've gone through detox, but understand that some drugs require detox while others don't. Most important thing for us to remember, of course, is that a person normally is going to benefit from a combination of these approaches, and that a combination needs to be based on their assessed needs. We also need to realize that people are not static, and so an individual might have tried an approach in 2010 and had moderate success, but then later on relapsed, may even relapse for a number of months or even a year or two, and now they come in and they seek care again. It is often the case that we cannot simply replicate the care they had previously. Even if it was effective in the first iteration, it's often necessary to adjust to a new approach now, to a new agency now. And so sometimes people find that even though it's a residential treatment facility that has a list of services that look the same as the one down the street, they're better off in place A than they were in place B, just because of the subtle personal differences. And before we wrap up, a few last words about harm reduction once again. And I said in Module 6 that I've become an advocate for harm reduction because the evidence supports that this is a highly effective approach. And if you looked at what we learned in the stages of change material, you can see why. Because harm reduction approaches meet people where they are and allow us to support that person in the pre-contemplative and contemplative stages instead of leaving those stages really up to family or the community or to the individual on their own, which is almost a lottery-based approach, and then just being ready when the person comes into the door in action. That's not realistic, and we need to be providing supports to people before they even know they're getting supports. And that's what harm reduction does. It's highly effective with people who are in that pre-contemplative or contemplative stage. These are gateway services, and the idea is that the person comes in the door thinking that all they're going to get is a clean needle or a low barrier shelter where they're allowed to sleep, have a meal, and go out the next day, and they can do whatever they want under the sun. But when they come back in every day, they're gradually starting to build social connections, trust, and relationships. And that means we're addressing the person's needs holistically and gradually. And so that person may get nothing more than a warm bed, a nutritious meal, a shower, and clean clothing. But when you think about it, you're in a far better position to be able to make choices in your life when you have those underlying needs addressed than you were previously. These services also recognize the value of relationship and non-judgment, and recognize that when we talk about people coming into low barrier shelters, what we mean is those people cannot seem to handle very many hurdles whatsoever. If we're constantly correcting their behavior, we're constantly correcting their language, we're worried about all of the rules, then we're probably going to simply have that person be rejected or alienated from us early on. So if we take a look at the research around the Insight facility, for example, it's quite substantial. And this is the research that was taken when you heard that the Conservative government was considering closing down the Insight facility. And you can see that the statistics here are rather remarkable. So in the years since 2003, there were 1.8 million visits, and this meant there were more than 12,000 users who were actually registered at that site. So in 2010 alone, there were 312,000 people, an average of 587 injections a day, and 3,383 clinical treatment interventions. In other words, the people were actually provided with more than just a needle and just with a clean facility. They actually went further than that. There had people who had 221 overdoses that would have likely died or at least had a higher propensity of that, and nobody actually passed away in that facility. But as you can see, they actually have combined the clients with needed services. So they had 5,000 referrals to other social and health service agencies. Out of 12,000 individuals coming in the door in that year, 5,000 of them actually went on to other services. 458 admissions from Insight into On-Site, which is the adjoining detox treatment facility. So, and then 43% of those people went on to get further care. So you can see that it is a difficult thing to get people to get help. The recidivism rates of people who are going through drug and alcohol recovery are frankly depressing sometimes. It can be very, very alarming. but we need to be realistic about the process. We don't look at it as though a person will get one referral and go through the system in a progressive, forward-moving direction and never ever turn their back. The truth is that many people double back, often repeatedly, sometimes ending up in entirely different communities or even entirely different provinces. And the process sometimes takes years. But each time we do the right thing by a person, we make it more likely that they will go back and try again and overcome this very difficult process of recovering from addiction. That's going to end module number 7, and we want to thank you very much. We hope that this has been insightful for you, no pun intended, in terms of understanding more about the nature of addiction. And we really strongly encourage you to go out and find out more, because it is perhaps one of the least understood areas of mental health. And we particularly hope that those of you who don't see yourselves as drug and alcohol rehabilitation workers will start to understand that every first responder plays a vital role in terms of that initial interaction they have to helping people see the possibility of moving on to treatment, and especially for people who have tried it before and think that they cannot go back and be successful. Don't give up on people, because when we give up on them, they give up on themselves. Thanks so much. We'll hopefully see you in Module 8 to wrap up the Community Cares course.